Hello, everybody. I am Frank Konkel, executive editor for Nextgov. And before I introduce our panelists, I just kind of want to give a little bit of a set the stage for our conversation on AI in action. As Congressman Olson just said, that in February there was an executive order out from President Trump making the development and regulation of AI a federal priority. One of the early industries that's seen success so far in AI, this buzzword sort of technology that we hear about all the time, is the healthcare industry. And already AI systems have been used to diagnose common childhood conditions and sort of make predictions on things like who might be most prone to develop Alzheimer's. But it's very likely that AI can do a lot more than that. We're talking today about things like natural language processing, pattern recognition, offloading tasks that clinicians and other healthcare professionals do to these kind of technologies to free up time and resources and perhaps a whole lot more. So given the confluence of events that we're kind of in right now, it's a great place to hear from some of our government folks on where the government is at now in AI and where we might be in 2030. So with that, I kind of want to introduce our panelists, let them talk a little bit about their roles, their missions. They're all very different, and they all have a very different intersection with AI. We'll start directly to my right with Dr. Ryan Vega. And tell us about yourself a little bit.
Well, thank you, and thanks for having us. Thanks for everybody being here. I'm a physician by background, a hospitalist, and have been very fortunate in my time in the VA to get involved in various innovation activities, and have found myself being part of a team that looks at not only identifying early stage innovations, but also scaling those across the enterprise. And we have a lot going on right now in terms of advanced technology, where we're really focused on the application of AI in improving productivity. We see productivity as sort of a really intersection of where AI, in terms of real use cases, can really help advance healthcare. And I think that's something we'll talk a little bit about today, sort of separating the myth from reality. But those two, I think, advancing productivity and then helping us use other emerging technologies are really, I think, where we're starting to see incredible value and incredible drive and promise over the next decade.
Dr. Lee.
Yeah, I'm the chair of NIH AI Special Interest Group. NIH, probably everybody knows, is the National Institutes of Health. It's one of the agencies under HHS. We have 27 institutes under NIH. And I'm the chair of NIH Special Interest Group, was set up 16 years ago. So at the beginning, we mainly focus on early detection. Probably everybody know that is try to detect like a screening for lung cancer and the different cancer stage use algorithm. And after that, we focus on diagnostic, like imaging and biosignals. And now we're really focusing on the therapeutics.
Okay. Dr. Rucker.
Don Rucker. I'm the National Coordinator for Health IT. Our office, known as ONC, is part of Health and Human Services as well. We're one of the divisions there. We've been heavily involved as an agency in working on getting electronic medical records out. As Congressman Olson said, first you actually need the data, right, before you can actually do things. Most recently, we've put out a large proposed rule on interoperability, right, because the glue to any computing is actually having these computers talk to each other. Historically, that has been hard both technically and often from a business point of view, because a lot of healthcare institutions are really designed to keep the information very internal, force you to be in their network. So that has not been often the configuration out there. So we have, along with Medicare, Medicaid, CMS, large proposed rules to get the data out. It's a very exciting time.
Good deal. So I'm going to have like 10, 15 minutes at the end of this panel so that you guys have questions, we'll get them answered. So the folks in the back, let me know when that is. We'll get to it. All right, let's level set a bit. So we hear about AI all the time, but respect to government, how far along are AI applications in healthcare today compared to the crazy hype that we hear about all the time? And you guys can all take a stab at this. You want to work down the line, Dr. Vega, you can start us off.
Sure. So, it was funny. I was telling Frank, my dad's an attorney. He doesn't know much about medicine other than the discussions we have. And so I told him I was coming to talk about AI. He said, good, well, finally we can train doctors to stop talking and listen more. And I said, look, I don't think we're replacing physicians anytime soon. So, separating the hype from reality is in terms of what can we really do right now. And where we're using, at least in the VA, AI is really to think about how can machines help us be more productive and efficient, right? So how can we train them to do something that is based upon pattern recognition of the application of right now structured data sets to really help us be more productive in clinical workflow or even offloading sort of administrative tasks that require some clinical expertise, freeing up a provider to go, a nurse to go be at the bedside more with the patient, or a pharmacist to go be in the clinic more. And so I think we have to be careful about really thinking in terms of how can AI actually be used, what are we using it for, and where is sort of the myth? This idea that a robot is going to be your provider tomorrow is really, I think, something we're not going to see, at least in my lifetime. I think where we're really going to see the advancements of AI is really in offloading what I call is non-productive work, non-value added work in clinical care delivery, and work that a computer can do just as effectively or efficient as an individual. And so I think that that's really where we've had to separate what are the use cases that we can apply real technology towards now. And then I think the other challenge is there has to be a healthy tension of not losing sight of where we continue to push the envelope. So in thinking about things in terms of precision medicine or advances in genomics and our ability to treat cancers, particularly cancers that are more heterogeneous like prostate cancer, to be able to diagnose more timely, but also to be able to customize treatments for various populations. I really think that's sort of the envelope that we need to push, because that's really the next step, the cutting edge in terms of, as the congressman was saying, really saving lives.
Dr. Lee, you've been in this group for 16 years. So what has changed in during that period of time with respect to AI and government?
For government, at the beginning, I think right now it's still in infancy. It's still not mature yet, and especially for clinical applications. And but the big revolution will come very soon, and all the technology will merge together, and that make a big difference. For example, at the beginning, we only try to find out the early detection, which is called preventive medicine. Then now we're working for diagnostic. The diagnostic, that means AI read, X-read, MRI, and CT, and billions records already read by clinician, which is we call still assistant. If it's an AI physician, that will be a different. Then we can talk about the next question.
Dr. Rucker, how about you? You've been in this space for more years than all of us.
Yeah, so I was a grad student in Stanford's AI lab in the mid-1980s. So the very first bloom of artificial intelligence had basically just passed, and we were in the first sort of little bit of a downward dip trying to figure out what we could do. So that was an era of things where, looking back, tiny computers and even smaller data sets, right? So the tools we had at that time were things like rule-based expert systems, very hand-engineered programs. Some of them were quite successful. If you look at programs like Mycin, pretty good diagnostic for general symptoms. But when you look at that era, with that small amount of computing power and that small amount of data, realistically, there was almost nothing to do. Things like neural nets, which came around, were popular in the early 1990s, just didn't have the data. Intuitively, we sort of knew it, right? A neural net with 100 nodes probably is not going to work like our human brain with 10 to the 10th neurons and 10 to the 13th connections, right? There's going to be something not just quantitatively, but qualitatively different. I think now and I'm proud to say ONC has been heavily involved in getting this data out and empowering folks there. We have vast amounts of data. The data can actually be pretty low quality, but the insights, because of the sheer volumes, if you can get a hold of the data, allow an entirely more powerful set of tools. So if you look at any of the current machine learning algorithms, pattern recognition, the statistical natural language processing, they're very, very powerful things now. So I think it's exciting. I think the initial things, I know there's a lot of excitement initially about diagnosis. That's a high legal hurdle to sort of hit on pure diagnosis, but I agree with the comments from the VA that the operational things are going to be huge. One of them, which hits all of us in the wallet, is actually the entire process of finding value in healthcare, paying for value. Folks here, I'm guessing some of you do know and some of you don't, but there's a vast industry in very, very narrow quality measures, right, between the federal agencies and the private payers. We don't even know what we're buying in healthcare when you get right down to it today. We know what we're spending, sort of. Those are pretty private things too. But we really have absolutely no idea where value sits in healthcare. So I think one of the first areas where these broad algorithms are going to be used is to better tease out what we're buying. That alone will be extraordinarily powerful because all providers are not actually equal. You know, the performance is different, different patients, different situations. Right now we have an absolute, certainly in the federal world, but in the private world, one-size-fits-all reimbursement scheme. So I think that's one of the first areas where big data can come in at massive scale.
Sticking with you, Dr. Rucker, you broached this in your intro, but you have a new rule on standards-based APIs.
Yeah.
Tell the audience what that actually means, and then what the ramifications are for individual patients.
Absolutely. So to Congressman Olson's point, in December 2016, Congress passed almost unanimously, right, pretty rare, a rule called law called the 21st Century Cures Act. Has a lot of provisions about FDA, but it also has a entire section on mandating interoperability. And what Congress did there is they said, instead of having narrow, proprietary, heavily gamed, very expensive, operationally difficult to access application programming interfaces, American providers and EMR vendors are going to be required to have standards-based application programming interfaces. This is very secure, OAuth 2, all of those things. What Congress wants is for us to have our medical record on our smartphones so that we own the medical record. We can take the medical record with us. We can shop for care. We can control our care. We can be engaged in our care. And the reality is those smartphones are very, very powerful. So all kinds of things are going to happen there. In order to do that, the law required rulemaking. So ONC, in conjunction with CMS, which provides the various provider incentives and disincentives, if you will, that's government speak, for payment, differential payment rates. We have a rule. It's out for public comment. So if you believe that you have a right to your medical record, and that should not be 100% controlled by your provider at your provider's choice. Our rule, healthit.gov, is out for public comment until May 3rd. We think it is going to be transformative in getting care back to you on your terms, not on the terms of other people, and in your economic control, and not in control of the various entities in healthcare that have aligned themselves to charge vast sums of money in opaque ways.
I imagine we can talk a little bit more about what the ramifications of having your individual healthcare record on your phone would be in the security perspective in a little bit. But I want to get some applications. I write about AI all the time, and it's kind of interesting that there's not a lot of legit applications in use across the government, sometimes even in the private sector too. Even though we talk about it all the time, you can find a conference every day this week if you wanted to, probably on artificial intelligence somewhere in the Beltway area. Dr. Vega, you have a couple applications that I thought were kind of interesting that we talked about a little bit earlier. I'd love to bring them up a little bit.
Sure. So one of our big national initiatives is the application of 3D printing for a whole host of I guess, use cases, anyway from custom printing orthotics and adaptive prosthetics for veterans coming back to pre-surgical planning. In the realm of pre-surgical planning, it gets a little bit tricky and time-consuming, but basically what some of our radiologists and engineers have been able to do is recreate and reprint a CT scan or an MRI. Now this is truly transformative because providers, surgeons can actually hold the anatomy. And as you get it better and better and better, they can actually feel the anatomy, see where blood vessels are. So imagine a complex head and neck tumor, not just going into the system virtually or seeing it in a 4D computer screen, but actually holding it, seeing where the vessel is going to cross, seeing where the nerves are, and planning for surgery before they go in. We're doing that in the VA. But in order to recreate that, it takes a lot of time for the provider to sort of sit at the screen, use software, dissect out, this is soft tissue, this is tumor, this is bone, highlight exactly what it wants to send to the printer, and then the printer has to be oriented in such a way that it recreates this. It's time consuming, but we believe it's revolutionary in terms of pre-surgical planning. Now imagine, because the heart sits in a certain way, the ribs are in a certain way, if you're looking at the CT of a chest, you could train a computer to understand the difference. In radiology speak, they use something called Hounsfield units, which is just density in the radiograph that can tell you this is probably this type of tissue versus this. They're now training the algorithms to learn and better understand, and then the algorithm could just recreate sort of what needs to be printed and send it off. So in the future, what we hope is actually that individuals that come in for trauma could have CT scans or radiographs recreated within less than an hour. And the surgeons could have in their hands the fracture, or say it's a fractured pelvis. They could actually see where things are, where potential bleeding risk are before they go in the operative case. So that's one real use case where we see sort of AI really helping in terms of our use of emerging technology. The other case is really an operational, and it's really a great story. A pharmacist at the Charleston VA Medical Center was doing what we call our claims adjudication. So a pharmacist is going through prescription benefits. We have business rules about service connection and whether the provider prescribed the right medication to the right veteran and so forth. And it takes a provider or a pharmacist to go and say, okay, yes, this veteran has this service connection to this disease, this medication was prescribed. It's pattern recognition. And so Corey spent about 5 years using open source algorithm and said, look, I think a machine can do this. That could free me up 5-6 hours a week, and I could go spend time in clinics seeing veterans. And that's what happened. And right now it's at 3 medical centers. It's 96.7% accurate in terms of its comparison to an individual doing it. The more data we feed it with ability, we think we can get it to be 100% accurate. Now this could offload clinical pharmacists across the country, put them back in the clinic, put them back on rounds, seeing patients and veterans, and having a computer do something that we think operationally makes us more effective and efficient.
And just put in context for the audience, VA has how many thousands of clinical positions across the country, and you guys serve 10 million veterans?
So about 9+ million service members and their families, 150 medical centers, thousands of points of care. So we've got a pretty sizable workforce. So this could be operationally incredibly impactful in getting providers back at the point of care to veterans where they belong.
And just, I want to backtrack on that use case. It sounded cool. So if I blow out my leg or something like that, and I go in, and we'll say 10, 15 years down the future, if this works, then they could scan my leg and figure out exactly how it looks in there so that it's individual, the surgery is individual, catered to me and my blown out knee, which I hope I never get, but you know, it happens to people. And then I could get all that taken care of in perhaps a few hours.
Yeah, you know, God forbid you're ever in some trauma, but by the time they got you into the trauma bay, as they call it, they get you to the CT scanner, they need to prep you for the OR, get everything ready, that the image could be sent directly to the computer, the algorithm would read, know exactly what to print, send it to the printer, orient the printer correctly, and then they'd have the replica ready for the orthopods as they're getting ready to go into the case.
Dude, that's cool. I sometimes have this fear of like doing something like that because my friends are getting the age now where they're starting to do those kind of injuries, you know, like playing basketball or something, they'll blow out a leg, an ACL or something like that, and it scares the heck out of me. Because I was one of those 85, Olson was it that said that he started this out in 85? That was the year I was born, so like I feel like, you know, you get to the early to mid 30s and you start thinking about those things a little bit, although I haven't had a need to get my individual healthcare record. Maybe I should do that. How hard is it? This is probably a stupid question.
We're making it easier by the day.
Yes, great answer. Dr. Lee, was there anything else you wanted to add? You have sort of a pending RFP that may or may not be released soon, but can you tell us a little bit about what that is? It could be something interesting in the future.
Yeah. So NIH support revolutionary research. We also call the breakthrough technology by intramural and extramural. A lot of people probably know NIH. Intramural is our in-house scientists, and extramural is all the universities and organizations and some companies. So by apply for grants, contract, and CREDA with the government, so they can NIH support their research. So I would like to give you one example about AI connected with 3D printing. It's printing the bones. So right now it's already in the preclinical study. And in fact, we receive a lot of AI diagnostic research from extramural, and we have several programs about AI connect with robotic surgery. The surgery was talking about it's not only doing diagnostic, doing the real work. That means AI control the surgery to calculate exactly which stage of cancer and where should cut, and the robot should cut exactly on the age of the cancer. So that's NIH intramural and extramural scientists really did a tremendous work for this AI research.
So one thing we do have some differing viewpoints on is the importance of data in AI. So I'm sure a lot of you are familiar with news headlines where AI-based systems are only as good as the data that they take in, right? So if they receive biased data sets or unequal data sets, they can produce then inequalities in the solutions or the insights that they put out. But there are some differences on this panel about how important the data is. Dr. Rucker, I heard you say that there's a lot of data. You don't always have to have high quality data to get important insights. But Dr. Vega, we were talking earlier and you said that data sets are important. The quality of the data is important for patient outcomes. Talk a little bit about the importance of data that goes into these systems and training them, and then what the future data sets of healthcare might look like down the line.
Yeah, so I think when we talk about the quality of data, separating what we mean by either unstructured or structured data sets from what is the actual data going into the algorithm. And if we look at actual health outcomes, we can extrapolate, depending on the research, about 70% of health outcomes, let's say 60% to be conservative, is based upon genetics and behavior. And I think one of the things that we lack is really good genomic data sets, but also the socioeconomic drivers of data. So we're using a lot of either claims data or episodic care delivery data embedded in the EMR, when we know that a large majority of clinical outcomes are going to be predicated based upon those behaviors or upon those genomic data sets. So when we talk about the quality, we mean sort of not the actual quality of the existing data, but how do we get all of these data, how do we get the data that we really need to drive clinical outcomes to really understand clinical variance? And I think a really huge step is interoperability. I mean, this is going to be, I think, transformative, because how much data lives on our phones about how active we are, our movement, how much information exists outside of the EMR that we don't truly have access to. So the idea of these APIs being incorporated into, whether it's Cerner or Allscripts or Epic, but also the ability to really share this data, I think is really going to make the quality of the data incredibly more valuable for us to learn about what's driving true outcomes and engagement and patient experience.
Yeah, I think, when you look at data, you have to, data costs somebody money to acquire, basically. And so I think when you look at data, you have to look at how it was acquired. that gets to things like the inherent bias of the data. In general, obviously structured data is vastly easier to just simply write computer code against. It's just simpler. But most of the structured data we have fits into two categories. So either it's machine generated, and so that's a pretty straightforward thing, whether that machine is an automated analyzer, an EKG, an MRI, what have you. That data is inherently structured because it came from a machine. Often we have to think about the data entered by clinicians. There's a vast burden and burnout problem. Docs in the United States are spending, on average, half their day sitting in front of the computer right now. There's a massive sort of drain of energy for a wide variety of reasons, to totally go into here. But I think we have to think clinically, what are we going to require of clinicians, and are we willing to pay that? The beauty as you get to larger and larger data sets is there are now lots of computational algorithms, essentially all of machine learning, to put it bluntly, that can take very, unstructured data. Now, all data is structured on some level, but what we would consider unstructured data and get some great insights out of that. So I think as you look at data and as you look at anything in the AI discussion, do the thought experiment. Where did this data come from? What do I intuitively think about the information that might be in this data? And then for those of you who have sort of a computational bent, then you can start thinking a little bit about what algorithms could you use to get it out. There are a lot of them. And the beauty now is if you're in school, hell, if you're not in school, go buy a book of Python and you can throw stuff together with TensorFlow. There's all kinds of things where you do not have to be a hardcore computer programmer these days to look at these analytic tools. So it's very empowering as well. There's stuff that literally you can do here if you put a little elbow grease into some programming. It's pretty straightforward these days.
Are most of the health records that we're talking about, is that mostly from visits to clinicians and your doctors going back, or it seems easy to think about the fact that almost all of us Americans have cell phones, and a lot of them have apps that track our activity, as you mentioned, Fitbits and things like that. How close are we to having data from those devices that are with us almost 24/7 incorporated into care or personal care?
Yeah, I mean, historically, up until frankly now, those things have been a huge divide. You could go to, areas where app developers and, either the app had access to the medical record, very rare, or, the vast bulk of health apps didn't. With the proposed rule and standards-based APIs, developers, again, gated by your giving that developer's app control to get into your medical record. You point the app at your provider endpoints. It is under your control. And so that, the security responsibility of thinking about what this app is, because you're giving it access to your medical data. But you're going to be in a position to actually get your medical data into any app. And then you can start thinking about the things were mentioned earlier about, for example, motion testing, gait testing, diet, heart rate monitoring. There are all kinds of physiologic and other parameters now that you can put in that are vastly richer because of the lack of APIs, because of the lack of incentives or requirements for EMR vendors and providers to open them up. It's been an absolute divide. Congress and President Trump and the White House heavily involved in bridging that divide and putting you back in care for you to do these things.
Just a random question, Dr. Vega. Is that sort of personalized care and maybe the potential to get information from mobile devices and things like that something that VA has considered, or could you feasibly see that working down the line? I just feel like we can get into the ethical concerns and privacy concerns that are inherent there, because we see what happens sometimes when you give large companies access to your data. I mean, you don't have to go very far back looking at companies like Facebook and how they've used, in some cases misused, that data. It's not far-fetched to imagine a scenario where healthcare companies or records providers would do the same thing. Is that something you guys could consider, or?
Yeah, so I guess it was weeks ago, maybe it was a little bit longer, VA announced a partnership with Apple to give veterans their access to their EMR, so their medical record. So I think you're seeing a commitment from the VA based upon that announcement that we recognize that that's the future. And I think it's important not only from a patient empowerment standpoint, but also from an ability to really move to that true population health management, which is, I think, how do you deliver individualized care to a population of folks?
I was doing a little bit of reading around on some of the more interesting use cases of AI that I've seen in the medical and private sectors, and one of them sort of ties into this conversation, which was a large study that had machine learning, AI-driven systems that were scanning Instagram posts. How many of you in the audience use Instagram or post on a regular basis? A few of you, okay. A lot of your kids probably do. I don't post enough, I'm told. But the AI in this study was designed, its goal was to see how well it could predict depression. And I don't think it takes, it doesn't take much imagining to see the scope of things that people post on Instagram, but these AI systems were just going through Instagram profiles and taking the language, the words that were used along with the pictures of posts to determine whether someone was happy or not. And part of that was going into diagnoses of depression. Gets into the concerns, I think, that are ethical concerns and privacy concerns. I want to address those. And we had this discussion a few days ago on how high the standards should be for these systems if they make diagnoses. Now, we've talked a lot about the potential of AI in freeing up resources and time for clinicians, but in some cases, those systems are being used to make diagnoses now, and one can imagine them doing more so in the future. What kind of standards should they be held to? The same as medical professionals? And what happens if these systems start making bad diagnoses or get people killed? What happens then?
Yeah, so there's the obvious ethical, I think, challenges that we're going to grapple with from AI. To that point, I'm of the opinion that anything in the clinical realm needs to be held to the same clinical validation that we put any emerging research through. That good academic research should be, well, I would say this, AI should be inescapable from good, sound academic rigor. We should have good clinical validation. We should be testing, and we should not just be sort of launching because we say, oh, this could be transformative, revolutionary. We tend to do that in medicine and then look back and say, oh, the data told us something different. So I think clinical validation is going to be of the utmost paramount as we sort of embark upon this new frontier.
Do you guys have thoughts on that as well? I'd love to hear them.
Yeah, well, so first of all, the FDA, which regulates these diagnostic devices, I think is sorting out what the appropriate degree of regulation in the digital space is for all the reasons you've just heard. It's extraordinarily difficult. Historically, there's been a concept called the learned intermediary. So if there is a clinician who's using that afterwards, there's really a backstop. If somebody says, does this make sense? Do I want to act? Do I want to treat? Do I want to treat a little bit? Do I want to give them chemotherapy? Do I want to do surgery based on this? So that's, I think, in the past. I think in the future, we're going to have, as a consumer society, have to exert a lot more individual judgment. This gets to the entire app space. I mean, right now, everything we do is computationally monitored by any number of things on our smartphones. I mean, just don't forget, your smartphone today, unless you have a federally locked down phone like federal employees are required to carry at times, but your personal smartphone uniquely identifies you from every other person on the planet, right? The configuration of the browser and the things that can be downloaded from your smartphone uniquely identify you. The cell phone, your credit records, your apps know where you are. So I think as a country and as a world, we have to sort of sort out that whole privacy thing. You saw the GDPR in Europe, the California law. I think it's pretty likely that Congress in this next term is going to, in some way, address privacy, but I think it is an open issue. There are one or two good things here. certainly in the things that we're doing, it is under the control of the patient to allow the app in. So there's far more security in ways now because it's not under your control now. So I want to point out that we're you know, from our point of view in the Cures Act and what we're doing in the administration, we're changing that paradigm to put you in control of it. That means you can also revoke access. Now, if your medical record is out there, you know, revoking it, it's a little bit of water down the stream type of thing. But you're going to be, I think, under more control. But I think we globally have to get smarter on it. We do not have great consent models, right? Everybody knows you scroll through something in microscopic print, you know, when you open up the app. I agree, right?
Yeah.
Did anybody ever read one of those things, right? So that's just, you know, that's just a delusional model of agreement. So I think we have to have something that is actual bona fide agreement. The companies vary. Apple in the health kit, which parenthetically uses a lot of the standards that, you know, you as taxpayers paid us to work on. Apple, I think, is pretty good. That data on Apple, unless you backload it into iCloud, actually never goes to Apple. So they're just the OAuth facilitator between the provider and the patient of that data, which is an interesting thing. You know, Frank has mentioned other vendors that have a totally different model of this, but I think we're all going to get smarter there.
They can't uniquely identify you by your Google search history, can they? Asking for a friend.
Yeah, we know that. Yeah, I have a friend with a problem. Yeah, what's dripping, really? I've been an ER doc for 30 years, so apologies for the crude attempts at humor. It's the only thing we know how to do. You can be uniquely identified more ways from Sunday. You know, in some bizarre way, the only real privacy we have, unless you want to be on the Supreme Court or run for, you know, Congress or the president, in which case I think you have no privacy, and you'll be relentlessly hounded, likely. But, you know, if you're an average citizen, the only privacy is anonymity. I will say it is we're going to also have better tools because all of these things generate log files. So you can actually, there are going to be tools to hold people accountable who are accessing your data. So for example, in medical records now, there's some fascinating AI companies. One of them is Maze down in Nashville, Tennessee, that can look if there is unauthorized access to your medical record by looking at pattern recognition of what a regular hospital employee, let's say these are typically hospitals with sick people where somebody, you know, where there's either personal interest or, you know, some newspaper, you know, TV, radio, internet type of interest, they can actually look at the patterns of use over the entire access pattern and determine unauthorized access, both for celebrities, which is relatively straightforward, but actually for each of you. So, you know, talk about use of AI. There's some very interesting things that will come out that way.
There's some pros and cons for sure. I want to open it up to some audience questions now for you guys. I have a few more, but we'll just start right there. Just wait for the microphone because I think this is being live streamed and recorded.
Hi, my name's Gina Bennett. I'm with Caliburn International, and I'm curious. You're talking about all of these data solutions in Gov, in healthcare, which is a lot different than data solutions and AI in other fields. You've got HIPAA, you've got all kinds of data privacy. What are you guys doing to address that in terms of, because that's a huge hurdle to overcome to be able to, you don't have AI solutions without aggregated data. You don't get aggregated data without overcoming the privacy. How are you addressing that?
So HIPAA, which is, you know, the Privacy Act, they're really, when you look at HIPAA, it's worth understanding HIPAA covers providers and associated business entities. So, you know, so it's covered entities, business associates. There are really two states under HIPAA. There's the state of you as an individual, where you control access. That's called the HIPAA right to access. So under the proposed interoperability rule, you can take an app of your choosing, point it at the provider's URL, once this is all finalized, and get your data down. That data is then yours, under your control, and if it gets hacked or misused, that's on you and the apps you choose. But ultimately, it's under your control. That's one thing. For the business, and of course those apps, if they come together and offer a valuable service a la Google, as was just mentioned, right, we'll use them, right? I mean, if anybody can remember search before Google, Alta Vista, ring a bell for anybody, right? I mean, search was horrible. You couldn't find anything, or you were sort of trying to navigate a tree in Yahoo. So if you add value, we'll buy in on that. The other state of HIPAA between covered entities and business associates, so that would be payers of all the different types, maybe machine learning, data analytics, those require contracts defining that relationship with the provider with whom you as a patient have responsibility. They currently have a ability, if the data is used for what's called in the trade TPO, treatment, payment, and operations, to do that in a contractual way without an incremental consent from you that's sort of signed off. But all of that data access, even if they're using standards-based APIs, absolutely has a written contract and strict accountability. Now, the other part of it, just to mention, is we're also working with a lot of the payers to actually build out these new FHIR, these modern AI support tools, to actually allow queries over an entire population. Because right now, the payers who provide, for most of the people in the room here who are paying for your health care have functionally no electronic access to the provider EMRs. So, the people who are buying our care, just think about this, can't actually see whether they're getting a good deal on our behalf, because for a variety of reasons, the providers do not provide access to stuff. So the payers actually have a very hard time outside of overinterpretation of claims data to know what's being bought on our behalf. So this cuts both ways. Long answer, but it's a complicated issue.
Other questions? Yep, we got two gentlemen in the front, and then we'll start in the middle.
I'm interested in the relationship you may have with your OIT. So we've got one OIT on this side, and we've got medical on this side. You gave a perfect example of a pharmacist down in Charleston had a good idea. He go to you? Did he go to OIT? How do you all work with that?
So what we think of as, in terms of being effective in innovation, is you have to have an ecosystem or a community. Particularly in government, in terms of government tending to be risk averse, you have to be willing to fail and learn from those failures and fail forward to have any successful innovation. We partner closely with OI&T because in order for Corey to be successful, he needs server capacity. Well, that server capacity doesn't come from us. What we sort of provide him is either connection points to subject matter experts to help refine those algorithms, or connection points in other VA medical centers who are willing to help create the same, I would say, infrastructure. So the local OI&T saying, we would support that idea. So we sort of build that community and connection points. It's never effective if your OI&T and your field are not connected. They have to be streamlined, not only in governance, which is really important, I think, in terms of where AI is going, in thinking about data governance, data access, but also in terms of innovation and application of AI. Those two are going to have to be in some way symbiotic and live in that same ecosystem. So we've been really fortunate to partner strongly with our OI&T, both locally and nationally, on various different initiatives that are using sort of cutting edge technology or advanced digital care delivery models, and in this case, partnering them with AI. So from an opinion standpoint, they have to be, right? I mean, health systems have to be integrated with their OI&T. And a lot of them, it's interesting, you have a CIO and then the CMIO, and they're separate, and it doesn't make sense. And where healthcare is going, I think those are going to have to be bridged.
Yeah.
Gentleman over here in the blue shirt.
My question is, with all these devices, the Fitbit and et cetera, Do you have a reaction to the notion of these people who chase this stuff for money, that insurance companies, for example, would say, well, we're not going to renew your life insurance until you put a smoke detector in your house because you claim not to be a smoker. Ditto for stuff you'd buy at Safeway. I could go on, but, my question is about the integration of these Internet of Things devices into the healthcare system and all that entails.
We got a couple more questions, so if you guys have 30 seconds, any of you want to take?
I think that, I think that's the reality of our lives is, I mean, that's the brutal truth is, right? Because how does this work? It's worth thinking about it. If there's knowledge, people are going to act on it. Certainly in insurance and a fiduciary thing, they're going to act on it. They have a fiduciary responsibility to act on it. I think we're going to get smarter on sort of digital equality and equity. You're going to have to uncouple those, and it's the same way, public schools, private schools, vouchers, right? I think we're going to have to get smarter about some of these new issues, but it's going to be discovered, and the reason people are going to do it is because the other half of the population gets a much cheaper insurance policy, and that's just going to drive, that's going to drive the care, and you decide, you want the monitor in your car and save whatever. We're going to make those decisions.
Dr. Lee, did you have any thoughts on that too, or not?
Yeah, I agree. So I think in the future, that probably is hard to avoid. And because, for example, the diagnostic and the treatment, everything insurance company will see it. So they will pay exactly what is they're supposed to pay.
There's another question in the front over here, I think. Well, there's a mic right behind you.
Thank you so much for bringing this out and all of the positive things. But I think what Mr. Konkel was talking is the fragility of the system, and that's what I think we're all concerned about. Like, for example, Equifax got the data. The federal employees were hacked, and thousands of employee information went out overseas, and bad state actors. I mean, it concerns me that we need to deal with this fragility.
So, yeah, I mean, the analogy I think that's fitting is this idea of the fortress and the frontier. Healthcare has existed in a fortress, and we're sort of, with all these emerging technologies, entering into a frontier where things are going to be very dangerous. And I think from an ethical standpoint, society is going to have to grapple with, let's take clinical variance. Imagine we have genetic data and socioeconomic data and behavioral data, and we find out that this group of individuals fares worse on a particular knee replacement. Doesn't matter that anyone's, what the provider does, they're just going to do worse. Should they pay more? Or should the provider have the ability to say, I'm not going to operate on these folks because I know that I'm going to be held accountable and their outcomes are worse no matter what I do. Those are, I think, real things that people are going to provide and say, we have to grapple with those. And I think there's a whole host of those examples that you could look at the other side of the coin. Doesn't mean we don't venture out into the frontier. iPhones can be used for horrible things, but none of us would give up our smartphone, and they've made productivities and advancements in life. So I think you're right. I mean, it is, the frontier is dangerous and scary, and we're going to have to grapple with a lot of these. But sort of agree with my colleagues that it's somewhat inevitable. We'll have to figure out as they come. What we do with the Equifax example is, what do we learn from it, and how can we take that learning and apply it to what we know is coming?
So for AI system, I think it's very important for build up from we call the outcome. It's evidence-based, outcome oriented. That means any treatment depends on the outcome. So, for example, treat cancer. So which stage of cancer after treatment, as which stage, and cured or non-cured patients survive 10 days, is all evidence-based. So not like right now. So AI will tell you exactly what is the outcome. Also predict what is the outcome for the treatment. not just waste the money.
And, you know, distilling down what you guys said too, a lot of this will fall to users, right? We sign away a lot of our rights when we download apps and sign long terms of services contracts or agreements like Dr. Rucker said. But a lot of people don't know what's actually in them. I think with something as serious as healthcare records and the decision to share those or not, there needs to be an intense education of users nationally to understand what that actually would mean. In some of the ramifications, we don't even know, because who knows what this event's about 2030. We're in 2019. We've got 10 years. Who knows what the hell it's going to look like, right? We're over time, so I wish we could talk longer because I have a lot more questions. But anyway, thank you guys for listening, and thank you guys for participating. This is so fun.
Thank you.